Hi, welcome back to JAMA Network Open Live. I'm Seth Truger, Digital Media Editor at JAMA Network Open.
Hi, welcome back. I'm Mike Berkowitz, Electronic Editor for JAMA and the JAMA Network.
Of course, if you're following us live, please feel free to send questions or comments to us on Twitter, Facebook, or YouTube. Either respond to us, use the hashtag, or respond to the comments below, and we'll try to get to it now. Or if not in real time, we can address it later.
And Seth, I understand our breakthrough innovation from last week broke through again, and we have another author joining us today.
Yep, absolutely. So our first paper is a time series analysis of firearm purchasing after mass shooting events in the U.S. By JNO and Doug Wiebe, who's joining us today.
Welcome, Doug.
Thanks so much for having me.
So this is great. I mean, there couldn't be anything more topical, and gun science is very hot, both scientifically as well as politically.
Right. So why don't you tell us briefly what you did in the paper?
Sure. We conducted an interrupted time series analysis. We were interested in looking at mass shootings in the United States, and we're curious whether mass shootings inspired changes in firearm purchase behavior. There are two reasons why this might happen. When a mass shooting occurs, it's reasonable to think that some people may be afraid and feel that acquiring a firearm could keep them safe. And second, another hypothesis is that following mass shootings, there could be concern that legislation may be passed that may make it harder to acquire firearms in the future and inspire purchase behavior right then. So how did we look at it? It's a real challenge to figure out what's the prevalence of this exposure, firearms in the United States. And we use data from an FBI data set that is on background checks. When individuals want to purchase a firearm, in many states they're required to undergo a background check. And we had a monthly count of requests to purchase any kind of gun, or handgun, or long gun. That was our exposure, or that was our outcome, monthly frequency of firearm purchases. That was our proxy for firearm purchases. And in order to look at that, we compiled a long time series, monthly over 18 years, of the number of, the timing of when mass shootings happened in the United States. And over this recent 18-year period, 124 mass shootings occurred in the US. These are mass shootings that have 5 or more fatalities. So a pretty high bar for saying mass shooting. And we conducted an interrupted time series analysis. And first we identified when were there spikes in firearm purchases, and did those correspond with the timing of mass shootings?
Yeah. Well, as you get it, what impressed me the most more than anything else is just the top level numbers here. In this 18-year period, which isn't that long, there were 124 major mass shootings and 234 million background checks done on gun purchases. That's just a huge amount. Just the prevalence there on both of those is amazing.
Yeah, it really is. I had to do the math. That averages out to about 13 million purchases a year. Yeah, or requests for purchase. That's right.
So unfortunately, we don't hear so much about the mass shootings with fewer fatalities. We hear about the ones that are much more dramatic. And so I was wondering whether you looked at different numbers in the mass shootings, whether that made any difference. We haven't talked about the findings yet, but I just kind of want to talk about the methods, whether there was a reason to take 5 to 10 fatalities versus 10 or more, or some other kind of stratified approach to the question.
Yeah, we drew the mass shooting database from a Stanford database on mass shootings in the United States, and there they defined a mass shooting as an event with 3 or more, I honestly don't remember now, injuries or fatalities. 3 or more injuries or fatalities. There were so many of those that for us to line them up month by month, in many instances, multiple incidents were bunched within a month. So it wouldn't let us identify whether any given shooting corresponded. Yeah. So for that reason, we raised the bar a little bit to 5, and then it spread out the incidents a little bit over those 18 years.
And do you have information about the black market or illegal or gun sale market, the amount of data that are escaping the data source you used to know how representative these legal purchases are of the total gun purchase activity in the U.S. during the same time?
We don't. No, we don't have that. So that's a shortcoming of the study. We haven't even really talked about the findings, but a
Yeah,
second
we will.
shortcoming,
Okay.
second shortcoming to jump ahead is that we did this study only at the national level. National time series for purchasing and national time series for um, mass shootings. And there may be local effects that matter. We were only looking at the national scale.
Okay. So you set things up for yourself. Why don't you tell us what you found?
Well, sure. Over these 18 years, we identified that, in fact, about 1 in 5 of the mass shootings seem to prompt an increase in firearm purchases. Similarly, about 1 in 5 mass shootings seem to prompt a decrease in firearm purchases. The latter wasn't expected. The former, the increases, was expected based on a handful of studies that have looked at single incidents, like the tragic Sandy Hook Elementary School shooting. Um, but we found that quite a number of these mass shootings seem to immediately prompt rapid increases over the next month in firearm purchasing behavior. Um, the fear hypothesis may be borne out in that finding, and we went further. We were wondering, was it specific types of shootings or characteristics that were the ones that seemed to be associated with an increase or a decrease in mass shooting behavior. And we really only found 2 variables from around 15 that seemed to have a signal. And it was those mass shootings that received a great amount of media coverage, and also those mass shootings that the more fatalities that occurred, seemingly the higher the increase in purchasing handguns.
It's really interesting. And looking at the overall data in Figure 2A that we can throw up there, it looks like to me like the two biggest spikes were basically Obama's re-election and the Sandy Hook Elementary shooting that you mentioned,
Right.
and then a little later with its Cedarville and then into Fort Hood. And from what I remember of those, there was just seemed like the closest we got to more gun control legislation actually going through. So that I think the fear of I don't know, gun purchases going away might have been part of that too. Obviously it's hard to tease out causality in any of this.
Yeah, hard to tease out causality. However, I think it is compelling that looking at so many, we found a strong signal in so many of these instances, including the election, Obama's first election and the re-election, corresponded with increases in requests for firearm purchases. And to step back a bit, why are we concerned about this? It begs the question: what are the implications of having more firearms, handguns purchased, and implications for public health? And there's a great body of literature that has established either having guns in your home or a higher prevalence of guns in the city where you live, or your county, or your state, or having state or county gun laws that are lenient with respect to firearms corresponds to a higher incidence of either gun homicide or gun suicide or gun unintentional fatality. So that's a take-home message that we're really interested in. It seems that certain types of mass shootings correspond to gun purchase behavior, in particular those that are covered broadly by the media. So we need to think carefully about messaging that we have when we cover these events.
Right. And particularly just looking at the overall trend, the purchasing just seems to be continuing to increase over time.
Yeah, that's right. Those trends for total purchases and handgun and long gun purchases definitely increase in those 3 figures.
So are the policy implications to your thinking those about coverage of these events then? Do I understand that correctly?
I'm not sure how to move the needle on coverage. And I think back to, I don't know how many years ago it was, but there was some feeling that covering suicide in the media could inspire copycat suicides. But I think that's been debunked. And now we realize it's very important to talk about suicide as a public health problem and reduce stigma around that and create opportunities for health. I'm not sure how to message this in the media covering of mass shootings, whether to message it differently. But if it is the case that a lot of mass shootings seem to prompt people to quickly go and try to buy firearms, and there's evidence that that's not a good idea for public health, we might want to consider policy around a short-term limitation on being able to purchase firearms after a mass shooting event, a bit of a cool-out period, for example.
That's an interesting thought. I think the standard is still in place with regards to suicides, interestingly. I mean, I think the press still have that understanding that probably when someone dies from suicide, they should not be promoting that message because of that fear of copycat. So that's really an interesting connection and would require some thinking through and some discussion, I think, by public health community as well as the culture at large about whether there's parallels to be had there.
Yeah, and this is really great work, especially given the challenges in getting funding and performing good firearm research in America with basically the political and policy limitations that we have here.
Thanks for mentioning that. Yeah, it is. Firearm injury is a massive cause of injury and mortality and disability and lost work wages, major public health and medical problem. But the research funding for this area is really just a drop in the bucket compared to funding available for other diseases, both from the NIH and from the CDC. So seeing more research funding made available for work, especially on figuring out what kind of policies can make communities safer, is a real priority.
Right, and just to make a fine point of it, firearm research and gun science, not to put words in your mouth, is not, the intent is not to take away people's guns. It's to understand how to have them in our society safely, the way we have swimming pools and automobiles in our car safely with regulations that take care of everybody.
Right.
100%. Yeah, we've chosen to live in a society where we have firearms, and there are ways to think about and identify how to do so safely, minimize risks for unintentional injury and self-directed harm and assault. That's right.
Great. Well, again, great study. It's been great talking to you. We're unfortunately out of time, but keep up the good work. I do want to add just one little plug for Ed Livingston's JEMA Clinical Reviews podcast today. Just released, I believe, was the third episode in a series on gun violence issues, which features, I believe, one of the guests today is Megan Rand, an emergency doc and firearm safety advocate and researcher.
Right, and you can find that on JAMAnetwork.com or anywhere you get your podcast. Just search for JAMA Clinical Reviews. JAMA Network has a firearms collection that features research, reviews, and opinion about gun science, firearm science, and public health. So check out our website. And thanks, Dr. Wiebe, for joining us.
Thanks very much.
Great. So moving on,
Yep.
Our next paper, not quite opioids as we're required by law to cover, but the association of a maternal use of benzodiazepines and Z-Hypnotics during pregnancy with motor and communication skills and attention deficit hyperactivity disorder symptoms in preschoolers by Angela Lupitelli and colleagues.
Z-Hypnotics. I love words that begin with the letter Z.
Right. Yeah. And lots of people love drugs that start with letter Z. So the Z-Hypnotics are zolpidem, zalopron, I think is the other one.
I think zopiclone.
Zopiclone. No, S-zopiclone is Lunesta.
Okay.
So, and I think Zaloplon's Sonata, I think is the brand name.
I think you're right.
Yeah, it's hard to keep track.
Okay.
But basically, this is an area where, unfortunately, there's a pretty big burden of mental health issues in pregnant women, and unfortunately, we have a lack of data about what drugs are safe in pregnancy because nobody wants to do big trials in pregnant women at risk for hurting the babies. So this is a pretty decent study they did out of Norway, because like most Scandinavian countries, they have big databases. They looked at a decade.
And homogeneous populations and 100% capture of outcomes for these populations.
Yep. So they looked from 1999 to 2008 for which women were taking these kind of medications for pre-existing anxiety, depression, and sleep disorders, and as well as looked at some other variables like whether or not they were also taking antidepressants or opioids. And basically, the good news is they found basically no major effects or increases in symptoms, as reported by parents in these surveys about their kids who are, I think, roughly around the age of 5 when they did the surveys.
So no statistically significant associations, but there's one finding that children born to women with depressive anxiety disorders who took these drugs in late pregnancy had greater gross motor and communication deficits than unexposed children.
Right. Yeah. So, the good news is there are no major findings of badness here. The bad news is there was not a zero finding, and it's relatively ends up being a small fraction of women who are taking these medications during pregnancy.
Right.
So we can't say it's absolutely safe. And there's a pretty good and I would say careful accompanying invited commentary that kind of goes into, it's like, this is good news that it's not worse, but it doesn't give everything a clear pass.
Right. So there were 41,000 women and children kind of pairs in this cohort, and only 283 were were exposed to these drugs.
Right.
And so when you take that number and you think of kind of a likely to be kind of a rare event, it's possible they just didn't have the numbers to kind of capture the exposure, which isn't to kind of scaremonger or anything. It's just that these are the data and these are what they showed.
Right, and also, the other thing is, they found the rates of the prevalence of about 10 to 15% of these mental health disorders in pregnancy, and it's certainly likely or certainly possible that the untreated maternal depression or anxiety or other problems leads to even bigger problems for the kids.
Got it.
So,
can I mention one of my pet peeves?
Of course.
Not about this line of research, but they reported their findings as beta coefficients. And the way where I grew up, you should probably report your measures of relative risk in clinically intuitive kinds of units. And I'm not quite sure what the beta efficient stands for in this instance. I think it is a linear change in the scale that they use to measure neurodevelopment in these kids, but I don't know what the range of that scale is. And these seem to be somewhat small changes in increments.
Yeah, I'm glad you said it, not me, because I was like, beta, is this the regression? Who knows? And it's again, just not what we're used to seeing for these sort of things, and it's harder to translate from that what that means.
Right. So we have their qualitative conclusions, which is no major findings, maybe some signal of findings, but it's unclear whether those are clinically significant. And as you said, I just want to kind of call out, we may have showed that in the invited commentary, I think the title says it all. These drugs in pregnancy are reasonably reassuring for neurodevelopment, but should we really be using them? So taking kind of a long view, we probably should be trying to avoid, if possible, while still caring respectfully for our pregnant patients, we should try to avoid psychoactive drugs when they're pregnant.
Right. And obviously there's a lot of nuance in the study, a lot of nuance in the invited commentary, but I love it when everything you need to know is in the title, and that title is just beautiful.
Right, exactly. Okay, what's next?
Next, the assessment of healthcare utilization and cost of targeted drug delivery and conventional medical management versus conventional medical management alone for patients with cancer-related pain by Lisa Stern and colleagues.
Okay, so I thought that was a mouthful, but when I read it, it kind of unpacked that long title.
Right, yeah. So basically, what they call targeted drug delivery are these spinal implants for severe pain for patients with cancer, and then they use the term conventional medical management to refer to what we call conventional medical management. And it ends up being a bigger mouthful because the people who get the spinal implants are also getting normal systemic opioids.
Well, that's because I think you need to fail normal oral opioids in order to be a candidate for this targeted drug delivery.
Exactly. And not only that, but it's not targeted drug delivery alone, because that only controls some of the symptoms, and most patients do need the combination of both.
Got it.
Yeah.
Is this kind of like patient-controlled analgesia where you can dose yourself? Do you know anything about that?
To be honest, I couldn't find enough of that in the study here, and I'm not familiar enough with it, so I don't know if these patients had any control over their titration or anything like that. But ultimately, it's one of the drawbacks is this is a database study. They were looking at the Truvan Market Scan commercial claims database, which is pretty good. You could get a lot of data out of there. There's a lot of good information on some fairly complicated patients. It's billing data, and as most of us know, our electronic health records capture very good billing data.
Right.
And they were able to get a whole bunch of a few dozen clinical data points from the patients, but they basically identified patients who got these spinal implants who didn't have other reasons to have spinal implants from what they could tell, and from the data did have cancer, matched them with some other patients in the database, and just tried to see where the overall healthcare costs in reasonable time periods. I think it was 2, 6, and 12 months.
Right.
If they had increased costs, because the thought being it's obviously not cheap to put in a spinal implant, and how does that affect cost? Do you get admitted to the hospital for complications and things like that? Or do you avoid going to the hospital because your pain's better controlled?
Right. And maybe one minor point is, if I understood them correctly, it's been recently approved for outpatient drug delivery.
Right.
So if you you need to presumably come in for the implant, but if you can administer your drugs, or somebody, your visiting nurse, can administer your drugs at home, that would reduce costs, reduce visits for more opioid refills. And that was the reason, I think, why they relaunched this kind of health cost and resource utilization study.
Right, yeah. And unfortunately, this study, again, is not clinical data, so they can't assess whether or not this is effective for patients. They did a pretty good job, from what I could tell, of matching the patients to the patients who did and did not have the spinal implants. Of course, it's really tough from these sort of databases because there might be unmeasured confounders, patients who didn't want the transplant or implants, who were too sick to get the implants in ways that don't get captured in the database, but they did propensity matching and the usual stuff.
Right. And I think, as we've said before, propensity matching is a great method, but it can only adjust for propensity to receive an intervention based on variables you can measure.
Right. And then they found, I guess the good news is at 2 months and 12 months, but not 6 months, a decrease in the overall cost utilization, which is good. Basically, if nothing else, this is an increase in cost, and it might be decreasing costs a bit. They found, I think it was about $15,000 at 2 months and $60,000 per patient at 12 months, which is pretty good. Although in the treatment cycle of a patient with cancer, $60,000 is not that big of a drop in the bucket. I'd say it's probably a cup in the bucket.
Right.
But it's not nothing. And not surprisingly, most of the savings was in decreased inpatient stays and decreased length of stay when the patients had to come back to the hospital.
Got it. So not necessarily a clinical paper, but it informs kind of the allocation of resources and maybe what insurers want to cover. And if this brings targeted drug delivery to more patients because insurers like the notion of cost savings, then it's ultimately a good clinical paper.
Right. And I always have some skepticism with these kinds of papers because there's, is this just are they just kind of like buffing the chart of their treatment or whatever it is? But the bottom line is if there's other data that says this works clinically, which they pointed to, and it's at least not increasing cost and probably decreasing cost and is pretty safe and effective, it seems good. We just published a paper in JAMA Network Open a couple of weeks ago by Caterino and colleagues looking at the burden of ED visits in patients with cancer, and there's a lot. Basically, a lot of, not surprisingly to any emergency doc or any oncologist or patient or family member family member of a patient with cancer, is patients with cancer have a lot of symptoms and end up in emergency departments a lot. And I think it was 55 or 60% of the visits were just for symptoms, things like pain. So if this is something that's effective and cost effective to keep patients out of hospitals, that's great for everybody, not just because it saves money.
And you've made really clear that this is kind of market scan billing data and not clinically detailed data. But there was a glaring omission here, which I don't know, guess what I'm thinking. But because there are no clinical data, and because patients who have pain that are refractory to opioids are likely to be sicker and have worse cancer, I wondered whether they were likely to die within the year, and their deaths and mortality, earlier mortality for the one group would obviously reduce costs because they're not spending throughout the entire year period.
I thought the patients might have had to be alive for the whole study period.
So I didn't see that in this. And
I might be missing it, but I feel like I saw some. They at least had to be enrolled into the insurance plan for at least 2 months after the treatment date.
Okay, at least 2 months. But that still leaves open. So, not this good study, but I was wondering, did patients, were there, something we haven't talked about in this broadcast very much is missing data. And there's lots of missingness, and that the bias towards an effect or no effect is always unknowable in that instance. And we don't have a lot of information on the missingness in terms of the numbers of patients who showed up for the 6-month and 12-month and who kind of made, which numbers of the cohort made it to all visits, some of the visits, or none of the follow-up visits.
Right. And there's good reasons to, when you're using database like this, to do things like make sure the patients have the same insurance for 8 months. But that also means you're only looking at patients who have private insurance through the same carrier for 8 months, which means basically, one, they're probably working because that's where most people get their private insurance, or related to somebody who is. And they have some sort of stability, both financially and probably job-wise, where they didn't transition in or out of either that coverage or into a different coverage, into Medicare, Medicaid, or being uninsured, which certainly in America, where we have probably 30 different ways to get insurance in one way or another, and there's a lot of churn in and out of different insurance coverage, that this is very specific to certain types of patients with cancer and continuous insurance coverage.
Got it. And you're making me realize as we talk about these things, this is the way editors think. When we're looking at manuscripts that authors submit, we're kind of interrogating them for all the different kinds of explanations that could account for the findings that are either in line with or at variance with what the authors are claiming, because we want to kind of work to develop a manuscript that delivers the most accurate and complete accounting of the data and the information for users.
But again, overall, I'm still pretty optimistic that basically, if nothing else, this shows that patients who got these spinal implants, who were compared to patients who were somewhat similar in a bunch of different ways, didn't cost a ton more. So this is not what's going to bankrupt our health system, probably.
Got it. And I think we have it on tape. If I ever were to have this disease and refractory pain, sign me up for targeted delivery. That's my advance directive.
Right. All right. Well, there we go. So that's it for the 3 papers we have.
Yep.
We've got.
What else did we publish?
Yeah, there's a bunch of other papers in the release. I think we're up to 15 an issue now. Some of the other ones, our featured paper this week is looks at enhanced usability EHRs with cognitive workload and measures of fatigue among docs. And not surprisingly, they found that if you do a little thing, and I think it was in Epic, where you make it the way flag results go to tired docs better, it takes less brain space.
Flag results go to tired docs better. I don't understand that sentence.
Oh, they just they changed the way they made a slight improvement in the way that patients, or that docs got
alerts?
Abnormal alerts.
Got it.
And it showed in a couple different measured ways that it took less brain space to process that.
Got it.
Which is good when we're we're getting thousands of cuts all over the place. We're tired all the time. All sorts of alert fatigue in our EHRs. So that's nice. Next one. This one's really interesting. So they looked at this for patients who have a diagnosis of cancer and continue to smoke, and found that they were more likely to fail treatment and more likely to have increased costs. So that's tricky. I don't want to victim blame in any way. Smoking is really addictive. And frankly, if I got a bad cancer and I was already smoking, I think that the risk versus benefit of doing something that's good for my future health might be a little off.
I think for me it would be deep dish pizza.
Yeah.
Okay.
Yeah, I don't know. I probably have better pizza than that. But
okay.
But we don't need to get into that. But it's just an interesting study to me. Another one. The Association of Medicare Spending with Subspecialty Consultation for Elderly Hospitalized Adults basically looked at how expensive it is to get subspecialty consults. I'm probably dating myself, but there's a great YouTube video out of I think it was a residency in Ohio a few years ago, on outside hospital, and you've got kidneys.
Yes.
We can get a nephrologist. You've got a heart. We'll get a cardiologist. And that's not a trivial amount of money. And there also gets into some questions about whether it should be general hospitalists who admit and consult different specialties versus having the specialties be the primary admitting team. And I spend most of my time in big university medical centers where there's all sorts of different issues with which teams and services manage which patients, but there seems to be an overall trend in America towards general hospitalists taking care of more and more patients, with the consultants just being consultants. What's
the message of this paper? What's the finding? Do you remember?
I don't.
Okay, very good. What's next?
Sorry. And this is another interesting one. They used they videotaped cataract surgeries and used deep learning to analyze it.
I saw that one.
And basically found that the deep learning could find some really interesting findings with this cataract surgery, and basically could be used to do quality assessment, to do future training.
Right.
And it's kind of the marriage of medical education, real-time video quality control, and using AI to figure out how to analyze all that data.
Right. It's kind of a surgical education paper.
Yeah, it's really interesting.
Yeah.
And then last, this is an interesting paper. They looked at the socioeconomic gradients and distribution of diabetes and hypertension and obesity in India, which was basically a weird confluence of factors where basically in India, people are generally getting, there's less poor in India, but they're also getting more of the diseases of wealthier nations. So problems like obesity, diabetes, and hypertension. But unlike America, where those problems are kind of concentrated more in the lower socioeconomic groups, it's actually the wealthier groups that have more of these problems because because one, they live more like Westerners, so exercise and eat like us, and two, because they have better access to healthcare. So basically,
They're being ascertained in a way?
yeah, exactly. So it's actually kind of the opposite of the gradients that you get in the diagnoses here in America, where the less money you have, the more diabetes you're likely to have. But there's so many different confounding factors and moving targets there that it's just fascinating to me.
Yeah, I think that's probably the case. And I am going to put myself on a limb and say it's been demonstrated, although I can't give you a reference, in many low and middle income countries that as they become westernized and acculturated to our diet and our lack of physical activity or more kind of desk job kind of lifestyle, that this is happening.
Yep, absolutely. So interesting stuff. And if nothing else, it's reproducible.
Yeah, right.
Which is always good to have. So I think that's all we got for today.
I think that's it.
Great. So thanks again for joining us. Of course, we'll be back next week. Be sure to follow us on all your social channels, Twitter, Facebook, YouTube, LinkedIn. Do we still have a Pinterest? At JAMA Network Open.
We still have Pinterest. Visual abstracts are on our social media channels, which you're probably following if you're watching this. And those are authored by this guy. So he does a great job. So spread those around. We also have a podcast that's relatively new. And since the last time we broadcast, it is now, I believe, on Apple iTunes, Stitcher, iHeartRadio, Spotify, and one more, Google Play. Yep. And if you want to look for it or look for any of the JAMA Network's audio, go to JAMANetworkAudio.com. That's JAMANetworkAudio.com, and you can kind of browse episodes and subscribe at any of those platforms that you listen to your podcasts on.
Great. And of course, you can always read the papers we talked about today, as well as the rest of them at JAMA Network Open for free, because it's completely open access at JAMANetworkOpen.com.
And sign up for our emails. You can do that on our homepage, JAMANetworkOpen.com. And our next release will be Fridays at 10 a.m. Central Time, which is Greenwich Mean Time -5, I think, because we moved ahead in the spring. I have to figure that out for our next time here.
All right. Well, thanks for joining us. Take care.
Take care. See you next time.